Assalamu alaikum. My name is Dr. Hassan Farooq, and today co-urology lecture of biochemical recurrence of prostate cancer. First, learning objectives of today is diagnosis, imaging, and treatment. First, definition of biochemical recurrence. Standard definition of PSA recurrence is necessary to accurately predict for clinical progression. In 2007, the AUA released the guidelines for PSA recurrence, defining it as a value of zero point 0.2 or greater with a second confirmatory laboratory value. This is also adopted by European guidelines in 2017. The goal behind unifying definition was to determine an early marker for treatment failure in advance of clinical progression and to use a low enough value to allow for patients to be candidates for early salvage therapy. For standard definition, it to be used as a comparison within different patient series. Several hypotheses exist as to why detectable PSA do not always translate to clinically relevant disease. And if benign disease remains in the prostatic bed, PSA production at very low levels by cells of non-prostatic origin, and PSA elevation is a result of residual low-grade indolent prostate cancer. First, prediction of
Just a minute. If you go back to the history of the prostate cancer treatment, then before the advent of this tumor marker, which is PSA, there was nothing available which can tell us whether there is any recurrence in the body once any treatment of prostate cancer is given. For instance, you have done a very good job of radical prostatectomy or maybe radiotherapy, because those were the two treatments available in the later half of the 20th century, the last century. But then in 1990s, perhaps in after 1985, this marker came up. And not only from the laboratory, it comes into clinical practice. And when it comes into clinical practice, everybody jumped in, and somebody was thinking, a lot of people were thinking that this was a marker which can give you a diagnosis. So you must not have a history, you must not have anything in your hand. You just do a screening test of PSA, and then you can have a patient who is having something beyond the normal range of PSA, then this is a prostate cancer patient. But that wasn't the case. Later, it was pretty evident that this was a very low potential diagnostic marker, but a very high potential prognostic marker. So if you understand the two terms, diagnosis and prognosis, then you will very well understand the usability of PSA. Now, PSA can only give you a clue whether there is something going on in the pool of patients having BPH as a common disease after, say, 50 years of age. But in that 50 years of age plus patient pool, there might be a patient who has got prostate cancer along with BPH, and that was something which was being said earlier in the earlier slide. But that smaller PSA value will only give you a kind of a guide towards something to act upon. For instance, if it is greater than the normal range, then you might add something to just make it a little bit more sensitive, and then you have to jump one step up, doing biopsy. Now, whether to do biopsy in all patients or biopsy in some of the patients, a PSA can differentiate between these two groups. But beyond that, PSA won't be able to give you a diagnosis as per its value. For instance, if there is a value of like 10 nanogram per ml, as compared to 20 nanogram per ml, then it is not necessary that the person having 20 nanogram per ml PSA is definitely harboring some kind of a cancer. It might be possible that there is a focus of prostatitis along with BPH that gives you a false positive high value of PSA, like 20 nanogram per ml as compared to 10 nanogram per ml. So the 10 nanogram per ml person might be having cancer, and a 20 nanogram per ml person cannot be having cancer. So that is the kind of confusion that exists at that time. But now it is pretty clear. We make use of PSA as one thing, and then we add on to something like, for instance, in our unit, we add to it prostate volume and calculate PSA density, because that is the only thing available. But there are four different isoforms of PSA available all over the world. So if we want to carry out something which is like further purify your definition of having a very purified form of PSA value that can give you diagnosis, then you add something to the normal PSA estimation. But this biochemical recurrence is something which is in the realm of prognosis. So once a treatment is given, there is some kind of a recurrence going inside the body, and that recurrence will not be uh, on the quantity, on the level of amount. It will not be able to be picked up by radiology, for instance. Then it is the first step of recurrence that can be picked up by means of biochemistry, and that is the biochemical recurrence. So now PSA is being used more as a prognostic marker rather than a diagnostic marker. So that is something which must be clear in all of our minds.
How prediction of biochemical recurrence? Clinical factors can be used to predict for biochemical recurrence. Pre-treatment PSA level, clinical and pathological stage, Gleason sum, the era in which the radical prostatectomy was performed, surgical margins, and length of surgical margins. Surgical margins and length of surgical margin have more importance, because if, for example, if a patient has surgical margins positive after prostatectomy, and PT2, and other patient which has negative surgical margins, and PT3. The patient with the positive surgical margins, PT2 have high incidence of recurrence. EUA risk groups for biochemical recurrence of localized and locally advanced prostate cancer. The low risk patient with PSA less than 10 nanogram per ml, and Gleason sum less than 7, and ISUP grade 1, and T1 to T2A. Intermediate risk patient with PSA 10 to 20 nanogram, and Gleason sum 7, and ISUP grade 2 or 3, and CT2B. PSA more than 20 or Gleason sum more than 7, ISUP grade 4 or 5, CT2 CV intermediate risk में. High risk any PSA, any Gleason sum, any ISUP grade or CT3, 4 or N positive, locally advanced. Now, imaging, TRUS followed by biopsy had 100% sensitivity in patients with PSA equal or more than 2 nanogram per ml, but CT gained popularity in recurrent prostate cancer. MRI used in detection of local recurrence after biochemical failure, and MRI has sensitivity of 95% and specificity of 100%. Biopsy to be performed at least 2 to 3 years after completion of radiotherapy to identify presence or absence of residual or recurrent disease and grade of disease. Prostasan. India 1 Quipomab antibody scanning incorporates an IgG monoclonal antibody that binds to prostate-specific membrane antigen. Its use in patients with biochemical recurrence have been limited because of lower sensitivity and specificity. Recommendation for prostate-specific antigen recurrence after radical prostatectomy. Perform prostate-specific membrane antigen positron emission tomography CT if the PSA level is more than zero point 0.2 and if the results will influence subsequent treatment decision, have weak strength. In case PSMA PET CT is not available and the PSA level is equal or more than 1, perform fluocyclovine PET-CT or choline PET-CT if imaging if the results will influence subsequent treatment decision. It is also a weak strength. PSA recurrence after radiotherapy. Perform prostate magnetic resonance MRI to localize abnormal areas and guide biopsies in patients fit for local salvage therapy have weak strength. Perform PSM PET CT if available or fluocyclovine PET CT or choline in patients fit for curative salvage treatment has strong strength. Treatment of biochemical recurrence after radical prostatectomy. Salvage radiation therapy, androgen deprivation therapy, and whole pelvic radiation. Salvage radiation therapy remains the clearest choice and best chance for long-term freedom from progression. PSA of zero point 0.5 nanogram per ml or less is appropriate cutoff for initiation of salvage radiation. It is clear that many patients have long-term durable disease-free interval after salvage therapy. Failure after salvage radiation therapy can be due to persistent local disease, recurrence of local disease, or persistent metastasis or development of metastatic disease. Dose response with the salvage radiation therapy, certifying patients into groups based on dosage of radiation rate and biochemical failure at 5 years was low radiation 57%, moderate 46%, and high 39%. Higher dosage of treatment lead to improved outcomes with limited side effects in primary treatment of prostate cancer. Concurrent androgen deprivation therapy with the salvage radiation therapy. The use of androgen deprivation therapy may sterilize micrometastatic disease, shrink tumor burden, making it more amenable to local salvage therapy, and potentially work in synergy with the radiation therapy to treat remaining cancer cells. Guidelines for second line therapy after treatment with curative intent. Local cellular treatment recommendations for biochemical recurrence after radical prostatectomy. Offer monitoring, including prostate-specific antigen to EAU low risk biochemical recurrence patients have weak strength. Offer early salvage intensity modulated radiotherapy plus image guided radiotherapy to men with 2 consecutive PSA rises have strong strength. A negative PET or CT scan should not delay salvage radiotherapy if otherwise indicated have strong strength. Do not wait for a PSA threshold before starting treatment. Once the decision for salvage radiation therapy has been made, salvage radiation therapy at least 65 hours should be given as soon as possible as strong strength. Recommendations for biochemical recurrence after radiotherapy. Offer monitoring, including PSA to AUS low-risk BCR patients have weak strength. Only offer salvage radical prostatectomy, brachytherapy, high-intensity focus ultrasound, cryosurgical ablation to highly selective patients with biopsy-proven local recurrence within a clinical trial setting or well-designed prospective cohort study undertaken in experienced centers has strong strength. Salvage radical prostatectomy should only be performed in experienced centers at weak strength. Recommendations for systemic salvage treatment. Do not offer androgen deprivation therapy to MNOR patients with a PSA doubling time more than 12 months have strong strength. PSA recurrence after definitive radiotherapy. Similar to PSA recurrence after radical prostatectomy, biochemical recurrence after definite radiotherapy precedes clinical failure. This gives ample warning of potential disease progression to initiate secondary or salvage treatments. The standard definition of PSA failure as developed by Gastro was determined to be three consecutive rises in PSA level after another PSA, with the date of failure as midpoint between the another PSA and first failure. So an examination of BSA is more robust in predicting clinical outcomes. It was found to be significant predictor of metastatic disease, disease-specific mortality, and overall mortality. PSA nadir plus 2 nanogram was most significant predictor of all three outcomes compared with all other co-varieties. Post-radiation PSA bounce. PSA bounce is defined as elevated PSA of 0.1 0.5 nanogram over the pre-bounce PSA level with a subsequent decrease in PSA level. It occurs secondary to post-treatment prostatitis or even from delivery of a sublethal dosage of radiation-associated delayed cellular death. Patients who undergo transient rise in their PSA should be closely monitored because not all men are destined for biochemical failure, let alone clinical. PSA only recurrence after definitive radiation. PSA only recurrence after definitive radiation for prostate cancer leads to clinically relevant outcomes such as local and distant failure, along with cancer-specific death. Men with PSA elevation after definitive radiation therapy are candidates for salvage therapy, second-line therapy like androgen deprivation therapy or radical prostatectomy. Furthermore, patient comorbidity and age must be considered before the initiation of second salvage therapy.
Sure. Now, you see, the whole scenario is quite confusing. Quite confusing when you are in a clinic and you want to decide for your patient whether there is something in terms of biochemical recurrence. But just to keep it simple and to keep it simple in a way that everybody should understand and apply the knowledge that is there in the textbooks as well as in the guidelines. The whole story is about something which is a localized prostate cancer. Now, the treatment for a localized prostate cancer are only two: one, radical radiotherapy, and the second one is radical prostatectomy. Now, if we take one thing, that is radical prostatectomy, once the patient is through radical prostatectomy, after say 1 month post-operatively, the nadir value of PSA should be 0.000. That is three decimal places. After the decimal point, three decimal places should be 0, 0, and 0. That is the ideal, and everybody should fall into that ideal kind of a situation. If you have done your job properly, then the patient should be in that kind of a situation after 1 month post-operatively, after radical prostatectomy. Now, what you do is after every 2 to 3 months, you follow your patient with serial PSAs, and you are on the lookout whether there is anything called uh, a value of PSA which comes up on your radar, on your screen. Now, at the third place of the decimal point, there might be something coming up, maybe after 3 months, maybe after 6 months, maybe after 5 months, and that may be 0.001. If that is the case, don't do anything. Just keep your vigilance, keep your patient under surveillance, and keep your fingers crossed that there is now biochemical recurrence, but the point hasn't been reached when you can act upon and do something to control the disease. So the disease is occurring, but it is still at the biochemical level, but not at the level at which you can interfere with. When there is something at the second place of after decimal point, that is 0.02, for instance, or 0.01. 0.01 is acceptable, but if there is 0.2, this is not acceptable. Now, this is the point at which, if your patient comes up, then this is the advantageous point at which you can interfere. You can do something called PET CT scan. You can do something called PSMA PET, just to see whether the disease is still there in the pelvis or it has gone out of the pelvis. And if it is there in the pelvis, you you subject your patient to radiotherapy, right? So this is the story of a radical prostatectomy. Now come up with another patient. This patient has got a radical radiotherapy as a first line treatment. The procedure remains the same. Patient will have post radiotherapy PSA follow up. After every 2 to 3 months, there will be a PSA value. You always look out for the 3 decimal places. If there is something happening at the third place, don't do anything. If there is something happening at the second place, don't do anything. But if there is something happening at the second place, which means just after decimal point, 0.2, this is the point where you have to act upon. So practically what has been written in the guidelines is telling you something in details, but you have to adjust yourself in these terms. Remember only 2 things. After radiotherapy, the first decimal place is important. After prostatectomy, the second decimal place is important. Just to make you sensitive enough to put in something post-operatively as a second line treatment. Now that second line treatment, what it should be, it depends upon the restaging process which involves PSMA PET.
Treatment: salvage radical prostatectomy, salvage cryotherapy and brachytherapy, salvage IFO and adrenal deprivation therapy. Salvage radical prostatectomy after considered the most definitive way to eradicate localized radio recurrent prostate cancer. 10-year cancer specific survival to be as high as 70% to 83%. Surgical outcomes correlate with pathological stage, extracapsular extension, seminal vesicle, and lymph node invasion. The resistance to perform such operations is due to the inherent risk for significant morbidity. Up to 50% of the patients who undergo salvage surgery will experience major complications. Rectal injury 6 to 15%, bladder neck contracture 20 to 28%, and urinary incontinence 40 to 60%. Robotic surgery gained favor in last 10 years. Advantages include decreased blood loss, better visualization, and shorter hospital stay. Meta-analysis showed 2/3 of all patients were free from recurrence, 60% were continent, 26% were potent, and 16% suffered complications requiring intervention. Patients selected for salvage radical prostatectomy should have biopsy-proven radio recurrent prostate cancer, at least 10 years of life expectancy, lack of identifiable metastasis on imaging, and a PSA level of less than 10 nanogram. Salvage cryotherapy. Patients best suited for cryotherapy are those with localized treatment failure after radiation therapy with biopsy-proved disease, because approximately 1/3 of the patients with biochemical failure will have a positive biopsy result. Candidates for salvage cryotherapy should have a reasonable life expectancy and must undergo a full metastatic workup with cross-sectional imaging, CT abdomen, pelvis, or MRI, along with a radionuclide bone scan. Pelvic lymph node biopsy should also be considered in high-risk patients. Patients with pre-salvage PSA less than 10 nanogram per ml, ideally less than 4, and PSA doubling time equal to or more than 16 months predictive of successful treatment. And complications in cryotherapy, urinary obstruction, urethral sloughing, and urethral stricture, rectal pain, scrotal edema, and hematuria, uterorectal fistula, most complication. Brachytherapy. High dose rate brachytherapy has gained attention because it has the ability to implant the seminal vesicles and treat extracapsular extension while limiting the dosage to surrounding organs through a conformal delivery. Salvage high dose rate brachytherapy is a promising modality for patients with radio recurrent prostate cancer. For low dose rate brachytherapy, suitable patients are prolonged disease free interval from primary treatment to recurrence, longer PSA doubling time, and lesson score of 6 or less, PSA level less than 10, and no evidence of extracapsular extension or seminal vesicle invasion. Salvage high intensity focused ultrasound after the radiotherapy. Treatment has acceptable cancer control outcomes. Patients who demonstrate any rise in PSA after IFO should be watched vigilantly. Furthermore, patients interested in local high intensity focal ultrasound therapy should be counseled before therapy about the risk of residual disease and need for secondary therapy if failure occurs. Androgen deprivation therapy after biochemical recurrence following radiation therapy. BSA elevation after definitive radiation therapy may be due to local or distant metastatic disease. Patients with biopsy proven local disease, no evidence of distinct metastatic disease, and some life expectancy can be offered prostatectomy, radiation approaches, and cryotherapy. Considering the potential morbidity of androgen deprivation therapy and the substantial cost, it is reasonable to start treatment in those patients at higher risk for distant failure. Patients with PSA doubling time less than 12 months have been demonstrated to benefit from androgen deprivation therapy with freedom from distant metastatic disease of 57% to 78%. Biochemical recurrence after radical prostatectomy offer monitoring including PSA, low resolution and weak strength, offer early salvage, image guided radiation therapy plus intensity modulated radiation therapy to men with two consecutive PSA rises have strong strength, and negative PET CT scan should not delay salvage radiotherapy if otherwise indicated, has strong strength. Do not wait for a PSA threshold before starting treatment once the decision for salvage radiotherapy has been made. Should be given as soon as possible as strong strength. Offer hormonal therapy in addition to some salvage radiation therapy to men with biochemical recurrence have weak strength. Biochemical recurrence after radiation therapy offer monitoring including PSA, UA low risk patients have weak strength. Only offer salvage radical prostatectomy, brachytherapy, IFO, or cryosurgical ablation to highly selected patients with biopsy-proven local recurrence within a clinical trial setting or well-designed prospective cohort study undertaken in experienced centers have strong strength. Systemic salvage treatment do not offer individual patients, I'm not patients with a PSA doubling time more than 12 months as strong strength. Summary of evidence. A rising PSA must be differentiated from a clinically meaningful relapse. And the PSA threshold that best predicts further metastasis after radical prostatectomy is more than 0.4 nanogram and NADR plus 2 after image intensity modulated radiation therapy plus image guided radiation therapy. Recommendations. Routinely follow up asymptomatic patients by obtaining at least a disease specific history and serum prostate specific antigen measurement. These should be performed at 3, 6, and 12 months after treatment, then every 6 months until 3 years, and then annually as treatment. At recurrence, only perform imaging if the result will affect treatment planning. Thank you.